Hi, my name's Deanna Rogers, and I'm a human and animal physical therapist with Good Life Physical Therapy for Animals. Today we're going to talk about the iliopsoas and do part one of getting into talking about the issues with injury and recovery. We're going to review today the muscle anatomy and innervation, the actions of the iliopsoas muscle, injury pathophysiology, discuss how to do an examination and palpation assessment, also talk about neuromotor patterning, and then goals of treatment. On this human anatomy scale, we have just the psoas major and the iliacus. The psoas major located on the ventral and somewhat lateral part of the vertebral bodies, and it starts about at T11 to T13, so up in here, comes down caudally, crosses over in the groin area, and then will attach along with the iliacus to the lesser trochanter. The psoas minor goes anywhere from about T12 to T13, and in some literature even shows fibers as high as up to T9 and T10, coming down to about L4 and L5, and then crossing and attaching to the iliopubic eminence here. The iliacus starts in the bowl of the ilium, and on the ventral side of the dog coming down and again joining with the psoas major, crossing over the groin and into the lesser trochanter. The iliopsoas is innervated by the femoral nerve, and in canines that are the root segments of L4, 5, and 6, primarily L5. So on this human scale, you'll see that it comes down between the iliacus and around the psoas major, and follows down into the groin area. In some cases, too, the femoral nerve is actually coming through the psoas major. It's important to note the relationship of the muscles to the femoral nerve, because when there's trauma to the iliopsoas, you can also get some irritation to the femoral nerve, which could be either from the mechanism that caused the injury in the first place, or it can also be from localized edema, as well as scar tissue that may form during the healing process. You could therefore see some neurological changes if the femoral nerve's involved. Other muscles innervated by the femoral nerve are the quadriceps and the sartorius, so you may also see some symptoms with those muscles as well. The iliopsoas action is primarily a hip flexor and helping decelerate hip extension. It can also do external rotation of the femur as well as hip adduction. Now, if you have primarily the iliacus contracting, it can cause a ventral pelvic tilt with some lumbar extension. If you have the more cranial portions of the psoas minor and major contracting, you might can get some dorsal pelvic tilt as well as some lumbar flexion. The iliopsoas is predominantly a fast twitch muscle, so it's involved primarily with running and jumping and twisting motions. So the main thing that we're going to focus on, particularly with regards to rehab, is the work that it does as a hip flexor, decelerating hip extension, and stabilizing the spine. The iliopsoas can be injured in basically two ways, a primary and secondary way. With the acute strain injury, that's a primary mechanism of injury, and it can result from traumatic overstretch of the iliopsoas with activities like running, jumping, twisting, and splaying. And the overstretch then causes trauma to the iliopsoas muscle, and this is particularly prevalent when the iliopsoas is activated eccentrically. The repetitive strain injury is more of a chronic process with iliopsoas problems, and it results in some microtraumas that occur to the iliopsoas, likely due to some maladaptive posturing from other underlying conditions that could be orthopedic or neurological in nature. So what happens is, as I mentioned earlier, the iliopsoas muscle is primarily a fast twitch muscle. The weakest part of the iliopsoas is around the musculotendinous junction. So that's the area that's most commonly injured when there is a problem there, but you can also have issues in the psoas muscle bellies as well as at the tendon insertion itself. You can get inflammation from the injury into the tissues that are injured. You can get fibrosis of those tissues and scarring. And then you can start getting abnormal shortening and adhesions that can cause some myofascial trigger points in the muscle and musculotendinous junction. It is possible with chronic muscle strain also that the iliopsoas just gets fatigued over time, and what happens is the muscle spindle there starts to become overactivated, and the Golgi tendon organ then also becomes deactivated, and that can result in some spasms and cramping in the iliopsoas muscle. You can get edema around the tissues that are injured, which I mentioned earlier, can also cause some pressure on the femoral nerve. What can happen over time is as the muscle adapts to becoming more of a postural muscle, getting that constant contraction in the muscle itself, it starts to fatigue, and we actually can see adaptive fiber type switching. So we start getting more type 1 fibers instead of the type 2 fibers. That's why it's so important when we're working on iliopsoas recovery that we work on the whole core system, getting it nice and strong, and the whole kinetic chain of the hind legs. The way that the iliopsoas may present when there's injury and pain there is it can be painful to palpation. And typically you have to be very careful when you're palpating around the iliopsoas because the level of pain can be such that it's not uncommon for dogs to nip or bite when you're palpating there, so be cautious with that. The other thing too, when doing a palpation exam, it's important to do that while they're standing, but also you can check it while they're lying down when you can get in a little deeper. They often are lame in some way. Sometimes it's just a shortened step length on their affected side, although issues can be bilateral, and then you would see both hind legs having a shortened step length. Sometimes they can even be non-weight bearing on the affected side. At a trot or run, you might see a skipping gait pattern on the affected leg. With static standing, sometimes they'll want to hold that affected leg more cranial. And with static standing, you may also see some TL kyphosis as they're trying to adapt and hold that iliopsoas in a shortened position. This may also increase the TL kyphosis whenever they're doing any movements that are challenging them to shift their weight caudally onto their hind legs. Owners may report that their dog seems stiff after rest, or that the dog may be reluctant to jump. You may see if the dog is an agility dog, they start dropping poles. They may be resistant to climbing upstairs or hopping in and out of the car. And also on examination, you'll typically find that there's some resistance to hip extension. Because again, the way that the psoas muscle is a hip flexor, whenever you're going to do hip extension, you're going to be stretching that muscle. Also too, we often find that there can be some trigger points, even in the calf musculature. As they're shifting weight more cranially, the gastrocnemius is working harder to try and keep that hock stabilized. On exam, it's important to get a good history from your pet owner, and also while you're collecting that, you can do a gait assessment and see how the dog is walking around in the room, and also see how they're posturing themselves just when they're standing still. With your physical exam, a palpation assessment is very critical in order to isolate tenderness or trigger points or spasms in the muscle, as well as feeling the comfort and integrity of the musculotendinous junction and the tendon itself. Some people do radiographs, and there's some question as to how valuable that is because you're not going to see much with regard to issues with the muscle, but it is possible that you could find something in the way of mineralization of the tendon where it attaches around the lesser trochanter are also signs of an avulsion. Radiographs may also provide information on any other underlying causes, such as hip issues, spondylosis, and those kinds of things. There's varying opinions on the benefits of MRI, but typically we find with history, gait assessment, and palpation assessment, that's usually enough to get a good diagnosis of an iliopsoas injury. So the costs related to the MRI may not be worth it with what you can accomplish with your own examination. Musculoskeletal ultrasound can be great in determining more specifically where the iliopsoas injury can occur. Typically in the clinic that I work in and the mobile practice I do, we often try a few visits of physical therapy when we suspect an iliopsoas injury, and then if we don't see that we're making some improvements, we may then pursue the musculoskeletal ultrasound to give us more information on what's going on there. Other things to think about when you're doing your exam that could be involving iliopsoas issues is if there could be some other underlying orthopedic things. Often we find in dogs with hip dysplasia and arthritis or stifle arthritis and patellar luxation, there might be some iliopsoas issues going on there. It's very common to find some iliopsoas discomfort, and it can vary in degrees during the recovery of any type of cruciate ligament deficiency. Neurologically, we may see iliopsoas issues in the dogs with intervertebral disc disease. And back to our anatomy, since we're looking at the psoas major and minor in particular, connecting to the ventral sides of these vertebral bodies, anything that involves the discs or spondylosis can affect the function of the iliopsoas muscle. Also, dogs who've had fibrocartilaginous emboli can have iliopsoas issues, particularly those that might have a T3 to L3 involvement. As they're trying to get stronger in their core and hind legs, often the iliopsoas gets overengaged and activated. Lastly, it's important to just keep in mind checking out the neck and forelimbs if they're having any issue up in that area that may want to shift their weight then more caudally. That could cause some iliopsoas pain, and I have seen that in some cervical dogs where they've had iliopsoas pain due to compensating for their neck issues. The other thing that we need to keep in mind are the neighboring muscles around the iliopsoas. So back here on the human model, here is the quadratus lumborum, which you'll see here on this human model, coming up from the ribs down to the ilium, attaches on some of the dorsal fibers of the psoas major, and then down to about L1 to L3, and then comes down and attaches on the ilium. This muscle actually is quite strong in dogs, a bit more so even than people, and it helps to stabilize the spine, and it also helps with movements bringing the ilium close to the ribs, and it's innervated by the ventral rami of the lumbar nerves. Okay, with a palpation assessment, and there'll be 3 videos you can see, one with standing, one with in lateral recumbency, and the other with the dog semisternal. When I do a standing exam, I try and come up over the longissimus iliocostalis, quadratus lumborum, and then you're going to go under the quadratus lumborum at about 45 degrees to get up here to where that psoas muscle belly is located. You also want to make sure when you're palpating that you come down nice and slow, caudally, to the musculotendinous junction, which you're going to feel around the area of the groin or a little cranial there. And again, note that can be very tender. And then come down to the lesser trochanter where that tendon attaches. This dog is my dog Marley. She's 13 and a half. She does have mild cruciate tears on both stifles, the right one more than the left. She also has some bridging spondylosis at L1, L2, and LS area, and she has chronic iliopsoas issues that we work with her on. She is deaf, so it sometimes is a little challenging to get her to stay still. Now we're going to try, oops, okay, stand. Good girl. Just gently coming up on each side. Okay. Come up a little higher. There we go. Gently. And then I'm going up into the groin, around that lesser trochanter area. You may also feel the pectineus at that time as well. There you go. Okay, and again, she's a little more tender on the left than the right, and I'm knowing that because I put a little more pressure on the left side than the right, and that's what made her twitch around. Okay. Here is a video of checking her in lateral recumbency, and it doesn't take much when the iliopsoas is tender to see them be uncomfortable. You can see when you examine this video that she does twitch a little when I get to tender areas, and I'm only putting as much pressure on that tissue that makes maybe the tip of my nail bed a little white. I'm not having to use much pressure at all. Some dogs aren't going to be comfortable laying in lateral recumbency, and this next slide has you being able to do an exam with them in a semi-sternal position. If your patient doesn't want to lay in lateral recumbency, you can do it with them in this position. And I'm just very gently feeling around that psoas muscle belly. I'm getting at the musculotendinous junction, up into the groin, lesser trochanter area. I could feel a little tremor when I'm touching there. And I'm going to find her iliac wing and then get into the iliacus a little bit here with my fingers. You can see there she's a little uncomfortable there as well. The other thing that's good to check when you're looking at muscle injuries and even tendinopathies is neuromotor patterning. It's important that all of the core and musculature as well as the kinetic chain of the hind limbs be engaging properly. And so I'll be showing you some video of how to do a neuromotor patterning assessment. The first one will be going over the core musculature, and it just involves doing a very small elevated stand and getting the dog to shift their weight a little bit forward and back, cranially and caudally. Sometimes too we add a little side bending or side pushing to see how the obliques and the rectus abdominis and transverse abdominis are engaging. It's important that these muscles are working well, because if we rehab the iliopsoas without good engagement of the other core musculature, we're just going to set that dog up to have another injury, because that iliopsoas is going to continue to act as a postural muscle if these other core muscles aren't working properly. Okay, what I'm going to feel for here is I'm just having her lick little pieces of string cheese, rocking her back and forth, and seeing if I can feel the obliques working, which I can. Checking her rectus abdominis, that engagement's good. And she's a little tight on the right psoas. Hi, once more. Oh, you found one. Here you go. Got it. And the left psoas. So they're a little bit over engaging for this activity. All right, now I'm just going to have her shift forward and back. I'm watching a little bit what's going on with her quads and hamstrings, and I do see some reciprocal engagement there. Oop. Start again. Over here. Good girl. This way. Step up. Step up. Yes, good girl. Get that one. Good job. I'm going to have her come around the other direction. Let's go. There it is. This way. Yes. And step up. Here. Yes. Now I can see her left side. Here we go. Good. Forward, back, and good reciprocal engagement there. Okay. Step up. There. Good job. All right. Forward and back. So those are engaging well reciprocally. Feeling her glutes now. There you go. Got it. Good. Good girl. And I can feel her glutes engaging. If I weren't feeling this with cranial caudal, I would do a little side-to-side pushing, really trying to activate those glutes more, but hers are engaging well. Okay, and step off. Sit. There you go. Exercise finish. Other neuromotor patterning muscle groups that we need to look at are the quads and sartorius, checking the hamstrings and their flexibility and also how they're engaging. Often I find if there is posturing of TL kyphosis, especially when you're asking the dog to shift caudally, that means the hamstrings aren't engaging well. So it's important to check those. The gluteal muscles, which support the hip and the pelvis, are very important to be activated properly and to be strong, to help again support the lumbopelvic region, which takes pressure off of the iliopsoas, acting as a postural muscle. And the pectineus, which we talked about earlier, because it's located right in that groin area at the musculotendinous junction of the iliopsoas, but it also is a strong adductor, which the iliopsoas does as well. So we want to make sure that's working properly. And then lastly, the gastrocs. So when we're talking about recovery of an iliopsoas injury, things that we need to address are the muscular tissues, the tendons, and the neuromotor pathophysiology that can be going on, addressing that adaptive fiber type switching, and things that we can do to help get more fast twitch fibers back into that injured iliopsoas muscle. We also want to address proper loading of the injured and deficient tissues, and thereby making the healing process more successful. Often what I find is as dogs start to feel better, pet owners have a tendency to let their dogs do too much and go back to running and jumping way far sooner than the tissues are ready to handle, and then you get a chronic, repetitive re-injury process going on. It's important too, when we're designing our rehab program, to address the whole lumbopelvic and hip kinetic chain, as well as the core muscles. We also want to try and identify what are the underlying causes of the iliopsoas injury, because ultimately we want to be able to prevent re-injury. So this concludes our segment about the iliopsoas and the first part of learning about its muscle anatomy and innervations, the muscle actions, the injury pathophysiology, how to do an examination and palpation assessment, and how to assess the neuromotor patterning, and broad goals to keep in mind when designing a rehabilitation program. Our next segments will be dealing specifically with recovery and rehab.